Today is Friday, August the 30th, 2024. This is a House Committee on Appropriations. Mr. Jacob, would you please call the roll?
Chairman McFarland?
Here.
Here. Representative Adams?
Here.
Here. Representative Amade? Here. Representative Bakala? Representative Bagley? Here. Representative Baralt? Here. Representative Butler? Representative Carpenter? Representative Carrier? Representative Coates? Here. Representative DeWitt? Here. Representative Fisher? Here. Representative Freeman? Representative Freiberg? Representative Horton? Here. Representative Hughes? Here. Representative Ilg? Here. Representative Kerner? Here. Representative LaFleur? Representative Lyons?
Present.
Here. Representative Mack? Here. Representative Marcel? Representative Owen? Here. Representative Romero? Representative Thompson?
Present.
Here. Representative Zarang?
Thank you. We have some members that will be joining us after water sector ends. Before we begin, Representative Mack has asked for a personal privilege. Representative Mack.
Thank you, Chair. I appreciate that. Wanted to take a minute and introduce a very close friend of mine, Livingston Parish President Randy Delat. He and I served together 4 years on the Livingston Parish Council before he became the Livingston Parish President, and I became a state representative out of Livingston Parish and Tangipahoa Parish. I want to say that I appreciate him coming today. I want to say that, Randy could be off playing golf or hunting alligators. Well, I don't know if it's alligator season yet, but he could be off fishing and doing things like that. But he took time out of his day today to come over here and to, just learn more and build relationships and doing everything he can on a daily basis to better the quality of life of the people in Livingston Parish. And just wanted to thank him and thank you for giving me the opportunity to for that personal privilege. Appreciate y'all.
Welcome to Appropriations. He brought you the perfect meeting to come to. Before we begin, I'd like to read a statement. I do appreciate everyone's attendance today, from legislators to Department of Health to our public, those that are here with concerns and questions. I appreciate you taking the time away from your family and your businesses as we begin a very lengthy and complicated process of addressing our potential budget shortfalls for fiscal year 25. As a body, we have significant work to do to solve the upcoming budget shortfalls and challenges. House leadership is committed to a collaborative process for finding solutions to these issues. We will be working closely with our colleagues in the Senate and the executive branch over the next several months. As we have all heard, the state is currently facing a projected shortfall of $340 million for fiscal year 26, $370 million in 27, and $508 million in 28. The shortfall amounts do not include items such as a $248 million for education incentives like our teacher and personnel stipends, differential pay, tutoring, and apprenticeships. Any addition to the operating budget to include these items or other services will only increase these shortfalls. For example, inclusion of last year's targeted education initiatives in the fiscal year 26 operating budget will increase the shortfall to over $500 million. There's no one simple explanation for why these shortfalls are occurring, but there are several contributing factors. Obviously, the expiration of the 0.45 sales tax levy, the expiration of the 2% sales tax levy on business utilities, vehicle sales tax dedication to the Transportation Trust Fund, and many other revenue issues. These shortfall figures will fluctuate as circumstances develop. Based on the evolving economic data, REC will refine its forecast prior to the release of the governor's executive budget. This means the figures we are working with today are not the final figures. And it is important, however clear from the data we have on hand now, that we do have an imminent problem that we must address. The shortfalls we see today are more than just projections on a page. As we will hear over the coming weeks, budget modifications can have a real-world impact on people's lives. Taxpayer dollars fund the services people rely on to provide care for their loved ones, educate their children, the infrastructure they use every day to get to work and get home, the health care that they rely on, and the public safety services and child welfare services the state provides to its citizens. As it stands today, we will not have enough to maintain these services at the current levels. Regardless of what the final figure for the fiscal year 26 turns out to be, at this juncture it is clear we need to look for efficiencies in government. This includes streamlining services and paring down unfilled positions, etc. The meetings the Appropriations Committee will hold over the next several weeks are just one piece of a complex puzzle that many of you have seen before and will see again in the future. Leadership is committed to taking a holistic approach to these budget issues that includes examining the dedication of revenues, the state's tax structure, and all operational efficiencies. My favorite. The hay is by no means in the barn. We have a lot of work ahead of us, so let's get started. First, we're going to begin with the Department of Health. As many of you are aware of, they do have a tremendous amount of state general fund, and they are the largest part of our budget, primarily due to the federal dollars that are generated within their agency. So without further, I'm going to allow Secretary Harrington to introduce himself, as well as Mr. Moranto and yourself. It's yours.
Good morning, Chairman. I am Michael Harrington, Secretary. I came in January, as many of you know. I come from the private sector, joined the team as Undersecretary, and a couple of months ago moved into the Secretary role when Dr. Abraham became Surgeon General. So this morning, certainly have many of our colleagues here. We've spent a lot of time since January looking at efficiencies and effectiveness, and in that process. But I won't let my colleagues introduce themselves, and then we'll get to our presentation in terms of the LDH. Drew?
Good morning, Mr. Chairman and members. Drew Moranto, Undersecretary for the Louisiana Department of Health. Came in as the Chief of Staff and was appointed as Undersecretary at the end of June. It's an honor to serve the state of Louisiana. Thank you for having us.
And good morning, Chairman and members. My name is Pete Krogan. I'm an internist specializing in addiction medicine. I see patients every Monday, and I'm the Deputy Secretary at LDH, so over the program offices, the non-Medicaid side.
So members, you have a budget overview that you can log on to on your computer and follow along with the slides that are going to be present from that they will be presenting today. Secretary Harrington.
Chairman, as we get started, I do want to at least acknowledge that since January, and working with this incredible team of people, there's no question that LDH, that we can be certainly more efficient, effective, or whatever. But I don't want in any way for people to think that we haven't been doing that, or that if you did that, somehow that would take care of the need. Because currently, and you're going to see that we are prioritizing currently, and we have other priorities that we're going to have to be able to do in order to meet things like Cooper Jackson that we have not currently done, which means you got to take money from somewhere within the system to be able to do that. So I want to recognize the staff, and I will tell you, they advocate every day to be able to prioritize, to be able to serve their communities. And we know, and certainly for myself as a hospital CEO, that you have to live within your means. And we're going to do everything that we know that we need to do to be part of this solution. And we thank you for the opportunity to at least present what we think makes sense to start with. And again, as Drew and Dr. Pete go through this, I think you'll see that we're looking at options that we're going to look at. But my part is I really want to start and make sure that we level set in terms of the means of financing. Because it's one of the key things, of course, that when you think about SGF, and if you'll take a look, it's 3.2, but the actual total is 9.9 billion. And when you think about that from the federal funding side, it's 71%, with 16% being SGF, 13 from other means, things like state stat debt and those kinds of services, grants, those kind of services. One of the key indicators we want you to at least take a look at, especially as we think about how we would address any kind of shortfall, is that 91% of the total LDH budget is appropriated to Medicaid, which means Medicaid, those kind of services, are going to take the larger hit in terms of the kind of services. Now, one of the things that we also did, and hopefully you've had a chance to take a look at this as well, is that there is a state health plan. And in that, there are 4 key areas. 2 of them you see up in terms of behavioral health as a priority. So as we've looked at where we would be more efficient or effective and how to arrange dollars, we're trying to also make sure we're keeping these in terms of outcomes we know as priorities in mind. Behavioral health being one of those key issues in terms of deaths related to drug misuse. I mentioned Cooper Jackson. We've got to, solve that problem by this time next year, which is going to require additional funding, additional hospitals in terms of being able to take care of that restoration recipient in terms of the community. And we know that in that Cooper Jackson settlement, we have very little time to continue this process. We have to do this. Community safety, which you can see as well in terms of readiness, and certainly we know from a Louisiana standpoint, we need to be there. Now, the other 2, chronic disease, these are the other areas that we're focusing on in terms of access to care. Things like the Senate Bill 190 and trying to pay physicians basically at a Medicare rate that take care of Medicaid, because right now we have major access issues when it comes to specialists and our Medicaid population. And yet we know from what other states have done, you create that access, you actually will create a much lower cost structure, because people aren't then waiting to have the disease or whatever their issue is addressed, or basically utilizing the ED as their primary care. And so you can see whether it's cardiovascular, certainly cancer rates, we're prioritizing those. And certainly when you think about maternal child, we know that we have work to do there in terms of certainly birth outcomes and services that we're doing. We had an opportunity. I think it is a great opportunity for Louisiana to celebrate. If you didn't see that, we're an inpatient unit for maternal, postpartum type services was opened at Women's Hospital. We had the privilege of participating in that. We understand from talking with Renee and his team, it's only the 4th one in the country. So I think we are doing some very specific things to address that. So what we also want to be able to do as we go through this process is think about the optional Medicaid eligibility groups. And within Medicaid, they have mandates, as you can imagine, getting 71% of your federal funding. CMS is going to have quite a few mandates when it comes to how you can spend the money and who you spend it on. So we wanted to make sure from a framing standpoint that we were able to address the optional Medicaid eligibility groups. And then the next part of that is actually the programs that are identified. These covered services, and as you can see, there's actually 2 pages of them. They account for about $821 million worth of SGF. They total about $5.5 billion in terms of actual money spent in terms of LDH. That's because, as you know, that matching fund. Now, I know that there's quite a few of you that are very in-depth of this in terms of the FMAP, in terms of certainly when you think about the FMAP in terms of that federal Medicaid assistance percentage. But we thought it would be helpful to, at least for those who may not, to understand the impact of that. as you can see, the federal government share the cost for Medicaid services. That's where that 71% comes in. As you can see, by federal law, cannot be lower than 50% or more than 83%. And you'll see on ours in terms of where we are in terms of that 68 or so percentage. Now, we also get some additional on children's type services in terms of that FMAP and in terms of additional. But as you can see, we've also identified what that means in terms of as that FMAP rate changes, what that means from an SGF standpoint. As you can see in that 2023, there was certainly it dropped, and a lot of that due to the pandemic and certainly those additional federal funds that were coming in. But as you can see, it's for the last couple of years, and certainly the current budget has now beginning to increase back up. And that certainly puts pressure in terms of the dollars related to LDH and certainly the SGF. But I think it's important to have that. One final note, when you think about, again, us having to prioritize and the kind of programs, because as the chairman said, we were going to impact people's lives. There's not enough operational, administrative type efficiencies within LDH, because you still have to run Medicaid and all the other kind of things that you have to do in terms of administrative, to not then impact people's lives. This is an interesting service in the fact that we cover, in terms of LDH through Medicaid, 60% of the births in Louisiana. And that means we have to have, I think, the sufficiency in terms of funds to be able to support that, especially as you go back to one of our key goals in terms of addressing the maternal fetal. So we wanted to at least start with that type of information. Many of you may have that from previous discussions and review, but we think it's important as we think about, and I'll give you one just key kind of idea. One of the things we've tried to do is take this FMAP and basically put it into a very simple formula. And this is roughly, it's not exact, but it's roughly, if you think about for every dollar that you either, when you take out, you're going to probably have to take out $2.12. Versus if you're spending and matching a dollar, you're actually getting $2.12 back. So that's the piece that we're having to, frankly, walk the line on in terms of how we develop these programs and services and be able to decide, frankly, this gut-wrenching component of who do we leave out when we're having to face these type of reductions. Because you'll see what that turns into in terms of services. So I'm going to turn it over to Drew, our undersecretary, that will walk us through some of the proposals that we're talking about, and certainly in terms of the, I refer to them, if I slip up and say FTEs, that means TO, just in terms of that world that I come from. So we're going to talk about the TOs as well.
Thank you, Secretary Harrington. So Chairman, committee members, I'm going to briefly walk us through some of the potential reductions that we were asked to consider to present to you today. Obviously, it's been mentioned several times that we do have an impending fiscal cliff scenario if nothing were to be done. When considering reductions, and the Secretary alluded to it a few times, we obviously, these are direct services. You know, these are Louisianans that are on various programs and simply may have no other way to be taken care of for their particular situation. So some things that I want us to consider as we kind of go through this is, you know, you'll have priorities, governor will have priorities, and, you know, structuring your budget to attack those. I think, you know, in recent years, you've seen a huge commitment to mental health, you know, and developmental disability and those types of populations. You know, our Medicaid program still covers 1.6 million Louisianans, and about half of those are children. It's been said a few times here, but obviously we have mandatory situations in which we have to fund, and then optional, which is some of the SGF target that we'll talk about today. We are complying with the governor's executive order in terms of efficiencies to be identified during budget development, which really we've just started. It's never too early to plan, and so I totally agree with the approach here, but we obviously still have some work to do to figure out, you know, where we can have some efficiencies and where that might make sense to invest in the priorities that I just briefly touched on. So this really just gives you a visual representation. What was asked of us was to look at a potential reduction of $100 million in state general fund in terms of our operating budget. And so you'll see that the darker blue is that SGF piece and the gray is the federal piece. Most of you have been on this committee or sat in health and welfare and understand that, that it's a significant impact overall. So in total, if we were asked to do this in reality, it would be a net decrease of $332 million for the department and for those services. Obviously, an impact. Patients, providers, employers, families, communities will absolutely be impacted with these types of reductions. So I'll just take us through what we've started identifying, and then I'll move into the conversation about TO, and I will touch on our 5 24-hour safety net facilities that are crucial to taking care of patients all across the state. So you have this list in front of you. We can obviously answer questions on the specific types of services, but eliminating pediatric day health care, PACE, and adult day health care waiver is a tough decision. I will tell you that there's a compounding effect when you start looking at these types of services, and that the example most people would cite in terms of healthcare is you don't want people going to the emergency room, right? It's much more expensive and usually not the best place for primary care. But in these types of situations, we have folks that are able to maintain some dignity and are not referred to a group home setting or a nursing home. That's kind of what these first three do. Obviously, very important to take a look at. Next, the repeal of long-term support services and community choice waiver rate increases. So this rate was increased in October of 2021 to about $18.52, up from $14 for LTSS and $13 for CCW. Clearly an investment. How many times have we all talked about workforce and the workforce need in this state? And you will hear me say that quite a few times, but I do think it's important to underscore that these direct care workers are on the front lines every day, much like our healthcare heroes in a hospital or nursing home setting. And so this will obviously be an impact. Next, as some of these programs look to be potentially reduced, you obviously have a state workforce impact as well. That's what that line represents. Next, as you know, we administer a hospital-directed payment program to all of our partner hospitals in the state that see Medicaid patients. And so this would eliminate the $20 million state general fund portion that goes to support a total of 70. Now, that's not the entire program, just to level set with you, but it certainly would be a reduction. These next two are similar in that y'all have made an investment, but you've made an investment in years where funds were more numerous. And so these two reimbursement rate increases total $15 million in state general fund, and would obviously, if we eliminated these, would roll back to the old rates for that direct care staff. The nursing home inflationary adjustment, if we had to flatten that out, it was $21.7 million in the current fiscal year. I don't have to tell you that labor and food are through the roof. CNAs are hard to come by, and we can't train folks fast enough. But obviously, a huge impact there. And that doesn't account for their rebase, which would happen in fiscal year 26 that we're all preparing for. Could be upwards of $30 million on top of that. So if this were to flatten out, you'd obviously see an impact there for a total impact of almost $70 million when you account for the federal piece. These next two are really in the developmental disability space in terms of eliminating transportation per diems and support coordination services. The support coordination services had been stood up under some ARPA funds, which we know are going away. And so the legislature made a commitment to continue to fund that so that folks would have access to services and the right services. CSOC is a key component in the behavioral health space in terms of taking care of kids 5 to 20 who really may be on the final leg in terms of going to the next step, in terms of maybe an inpatient facility or some intensive outpatient type scenarios. And, this is really a wraparound function that personally I think we should be investing in, and it's hard for me to talk about it because I know that the need is there. Lastly, Medicaid funding piece for inpatient graduate medical education. This is a component to fund additional residency slots across the state and would obviously be a $7 million reduction there overall, 23. So I'll just quickly go through. This is the information on LDH's vacancies, including the 24-hour facilities that I alluded to earlier. So we have a total TO of almost 6,500. 5,900 of those are filled. 545 are vacant. 68% of our vacancies are in the facilities. And so 8% of our workforce is vacant. I think the secretary would tell you that is fairly on par with the private sector. But the facilities, I know y'all have heard me talk about it already, but those facilities are in areas with a workforce shortage. And once again, that's that direct care staff that's needed and the ratios that need to be maintained to standard. And so that's a constant moving target for us, and something that I really think the facility leaders and LDH leadership have intently tried to work on these past 8 months. And so many of you are familiar with them, but they're located in Jackson, Louisiana, Pineville, and Alexandria. Next, I just want to take us quickly through the census trend for the facilities. So you can see capacity and beds filled are almost right there. And so I talked about that compounding effect earlier in terms of if some of these services were eliminated, we might find more residents in this type of scenario. So Central Louisiana State Hospital and Elms, you can see the census on the side there. And I'll just take you through Pinecrest and then Central Louisiana Supports and Services. So, Pinecrest relatively stays full. The average census there is around 415. And you can see that that's ticked up slightly in the last fiscal year. Central's ticked up almost 10, and we are pretty much at capacity. And then lastly, Villa, which is also in East Feliciana, has seen an increase in their census as well. Just a comment on vacancies. We've talked about some of the braided funding that we find ourselves in at LDH, and so that's no different here in terms of not every vacancy is supported by state general fund, just to put a caveat there. And obviously the division goes through the salary project every year and some of those attrition adjustments. So just something to consider when thinking about vacancies. All right, that is it.
Dr. Krogan, anything you'd like to add?
Just here for questions.
Okay. Up first, Vice Chairman Hughes.
Thank you, Mr. Chairman. Chairman, first let me thank you for your extraordinary leadership. Obviously, as appropriators, we are about to earn all $16,800 that we get paid. Because we have a yeoman's task ahead of us, but certainly we're up to the challenge. And let me thank Speaker DeVilliers for encouraging us to get out in front of this. And Mr. Secretary and gentlemen, let me thank you all for your presentation. I'm probably going to take a little bit more time than I normally do, especially since Representative Marcel is not here. I'm all for efficiencies. Let me preface by that. This represents devastation. We're talking about people's lives, and when I look at this list, the people that are primarily impacted are children and seniors. And I think that we have to, take that under consideration. And I'm not attacking you all because you did the job that we asked you to do. So I thank you for really laying this out. I'm glad you used the term gut-wrenching. Because it is indeed gut-wrenching. And as we approach Thanksgiving and Christmas, our senior citizens, our disability community, many of our families are going to have unnecessary anxiety. And I think that should concern us all. Let me go through this list a little bit and delve a little bit more. Pediatric day healthcare centers, because the public is watching this hearing, and so I want to be clear what's potentially at stake. 647 recipients, 23 providers. Can you delve in a little bit more what these pediatric day healthcare centers actually do and provide?
Yes, sir. I think for anyone that's caring for a child with developmental disabilities, I know that's a full-time job and then some on top of it. This is to try to provide some support for those families. It's really an alternative that keeps people in their home and with their families. And as the Undersecretary and Secretary mentioned, the alternatives are expensive and in facilities as well.
And I would assume not only are the alternatives expensive, you probably would have a capacity issue. So it's not necessarily a guarantee that everybody would be able to transition into, this more expensive facility. And then I can only conjecture that there will be residual impacts to Louisiana's workforce, because now if parents don't have the necessary assistance, and if they are working parents, now they would probably be forced to quit their jobs, and being that they have to forfeit the assistance. So this could certainly have residual impacts on Louisiana's workforce. Would that be accurate?
Yes, sir. Definitely.
Thank you. The PACE program, 512 recipients, 3 providers. Can you tell me a little bit more about the PACE program?
Sure. I think this is a vision for how we should really, what's the standard of care for our elderly folks, and it's wraparound services. It's thinking about how they can spend their time and the best way to give them dignity and a high quality of life. So it's a really comprehensive, innovative idea where you get a capitated payment so a set payment for elderly care. Unfortunately, also would have expensive alternatives if this were eliminated.
Thank you. I'm glad you keep using that word dignity. That transitions beautifully into number 3, eliminate adult day health care waivers. My grandmother will be 93 on Saturday. We're really blessed for that. Every time I see my grandmother, I'm reminded that she caught a city bus for over 30 years to go work at Woolsworth. And we're blessed that my grandmother is still able to live at home with some sense of independence. It seems as though eliminating the adult day health care waiver program would rob many of our adults of that dignity, and I assume that they would have to now potentially transfer to some facility outside of their home. Would that be accurate?
That's right. Impact to the patient, and then as you highlighted, to the family as well, that would not be able to work during the day if they had to do that primary caregiving role. Okay.
Going down to the staff elimination, first of all, I want to know, I know you highlighted the vacancies. Mm-hmm. If we were to leave all of those vacancies unfilled, what would be the cost savings there to state general fund? And I don't necessarily need a finite number if you can give me an approximate number.
We can give you that. I think what I would tell you is you're never funded for all your TO for all 12 months in a year. So I would have to get you a firmer figure on that. And then I did, Representative Hughes, you had alluded to it, but some of those vacancies are not supported with state general fund. So we'd have to get that breakout for you, but we're happy to do that.
Great. As we eliminate some of these programs, especially as it relates to Medicaid, obviously, if we don't fund from the state general fund side, obviously we forfeit federal dollars. Is that correct?
That's correct.
Okay. Right. I want to go down to the OCDD waiver providers. Our disability community has advocated forcefully and rightfully for so many years. And now these programs are potentially at stake. If we look at the increase for individual family support night service, and I know it's not lost on you 3 gentlemen, but being a caretaker is tough. It's physically tough, it's mentally tough. And now on this list of cuts, we're talking about eliminating that as well. So that's a problem. And then I want to delve in a little bit more on the Medicaid funding for inpatient graduate medical education. We already know that our healthcare workforce is stretched thin, and there's a high demand. So can you tell me a little bit more about the inpatient graduate medical education program, what that actually does, and eliminating that? What would be the impacts of that?
So this is really the state's effort to try to close some of those workforce shortages. I'm in the addiction med space. We have about 40 addiction med docs trying to treat this entire state population. We know we have shortages in psychiatry and OB, critical specialties that we want to train Louisiana citizens, put them in Louisiana residency slots. And that's what this funding really goes to, is to keep future doctors in Louisiana in the communities where they're from. So it's another really tough cut.
Okay, great. Well, again, I just want to say, thank you for getting this conversation going. I'm really glad that we are getting out in front of this, and certainly we have our work cut out for us. But I just want to be clear, there's not one single thing on this list that sits well with me. It's a non-starter, quite frankly, because it has direct impacts on children, adults, families, our workforce. And quite frankly, to cut anything on this list is inhumane. This comes down to basic humanity. And, I think we have a moral obligation, if nothing else, to ensure that we are protecting every citizen in our state, and that includes the least of these. So thank you again, and thank you, Mr. Chairman.
Mr. Chair, if I could respond to one statement.
Yes.
Representative Hughes, your statement about the fact that it's impacting children and seniors to the degree it is, that is who Medicaid LDH cares for. You think about that enrollment the Undersecretary mentioned, almost half of that is going to be children. So any of these kind of cuts is going to naturally impact the most vulnerable in terms of our communities.
Okay. Representative Horton.
Thank you, Mr. Chairman. Thank you, Mr. Secretary, and guys for being here. It took my breath away when I was looking, and I think it's important for every legislator to receive this, to see just how hard our work's going to be done to protect these people, and just how serious this job is. And you did exactly what you were asked to do. Let me ask you. Updating the service delivery model for the way we care for our people. I know in years past, took this conversation to the previous administration, because I don't think they had a update since it was implemented by Huey Long, to where you would look at programs that we have that are not giving us a return, are not really doing anything for our people, and eliminating those. I was told they didn't eliminate them because you would make 39 vendors mad because we're, still funding programs that are not working. And there's a more efficient way to serve the very same amount of people we serve, but a more cost-effective way. Are y'all doing that? Have we done anything like that?
Well, one of the key areas that we have started since January is in the MCO space with the managed care organizations. You think about the amount of money that's there in terms of LDH, and that almost $7 million that Undersecretary referenced, Drew. One of the key things there, we've been having quarterly operational meetings with them. We know that in 2 years we have to have a different model than we currently have in order to get the return on investment, certainly coming out of the private sector. That's I fully understand that. And that's one of the key areas that we have looked at. We also have looked at these other community programs to see, and I know the staff are working on this, to be able to basically be more efficient so we can cover more lives, and look at how to do that on a daily basis in terms of cost that is per unit or per person.
Yes.
In terms of approach. The difficulty with that is, having been since January, is turning that ship in a short period of time. I refer to it as I'm originally from Florida, so I know a lot about boats, and I'm Coast Guard in terms of a captain. And so many days feel like trying to turn a tanker without thrusters of any kind. Wow. And so what we were asked to do is, if you had to do this now, in terms of this transition. For instance, the MCO RFP is going to take us a good 2 years to be able to get that in place. The other thing that we're struggling with in terms of the cost side is dealing with pharmacy, because that is also driving major costs. Right now, we're seeing incredible increases in terms of that 10, 12% related to nothing but GLP-1s. And so we're having to figure out how to get ahead of that. So we're making those transitions, but we're also having to respond to literally stay within the budget that we have this year because of that. And then the Jackson Cooper piece that I mentioned, that population is somewhere getting close to 200 now. So we have to be able to have placement for them out of the corrections type of facility into more of a psychiatric type of facility. So we have looked at some solutions for that. That's the other piece we're working on. But your point is, we absolutely are doing that. It's the timing to be able to get that done and to be able to move it quick enough to get to that 105 million or potentially more.
And let me tell you, I could appreciate it. When I worked for my as a legislative assistant for Henry Burns under Jindal area, they had not, again, updated the service delivery model, and it seemed like it filtered always to cutting the very people that are the most vulnerable that we serve. And I know it would, when you start delving into Department of Health, as you start seeing the layers of the onion, and I know Tony Buckland knows this, peeling off, all of a sudden they start putting them back on. You have a monster to decapitate, and it's going to take years to do. But in the meantime, we want to do our best to help you, but to continue to serve. I mean, this is just. I mean, I've been to pediatric daycares. I know what they do. I know. And everything does cost, and your job is huge, because it is going to take years to get where we need to be, like I know other states have, with efficiencies rather than cutting services. So
we're as a team working to balance the immediate need as well as knowing where we need to be in 2 years. And again, it's going to take us 2 years to transition that MCO, just in terms of the RFP and the contract. And at the same time, change the pharmacy model, which are some of the key drivers in terms of costs within LDH. These programs, as you see, they make a difference. But all of them do. I mean, as I said to Representative Hughes, that's what we do, is we take care of seniors and children and people who need us on a daily basis.
And any of us could need you at any moment, any minute. Any of us could need you.
Yes.
And that's it looks like an impossible task, but I know this is how serious. It'd be great if we didn't have a deficit to give you 2 years of time, and continue to serve. So we've got to work it out, but do its little. I don't know. I don't have no words, but this is an eye opener, and I look forward to working with you in order to save these services somehow.
I do want to mention one other item on the TOs, especially for our state facilities. What we pay that direct caregiver is less than what they would make at Burger King, and substantially less than what they're going to make at the new Amazon distribution center. And so even though we say we have these vacancies at those facilities, we're still having to fill them, because you saw the census. So we're filling them through overtime and through agencies and other kind of services, which is costing us more than we would want. But at the same time, the people who do this work, and one of the things that we've committed to is getting off of the 9th floor. So you're talking about going to those facilities and the services. Last Friday, I was up in North Louisiana at one of the public health units meeting with one of the hospitals up there in terms of DeSoto. And as a team, we have committed to doing that. We try to set aside every Friday to actually go to a site, see what they're doing, how they're impacting lives, so that we're not just looking at numbers.
Thank
we're
you.
actually looking at what's happening in terms of the community.
You're looking at our people that we hear and advocate for, and I know that I've just met you, but I can see that it's painful for you as it is for us, and but no more painful than the people who live every day of their lives taking care of their loved ones. Because in my family, I don't see their disability. But the care is but the care they get is life changing. So I'm gonna do everything I can to help you, but while advocating for these services. But I appreciate you, sir, and your staff, because you have a monumental job.
It's really the staff. It's been they're just incredibly dedicated every day, and these are folks that I know, having come from the private sector, they could go. I would have taken them in any hospital I was in. These are awesome people who really do have to deal with that gut-wrenching decision every day right now, because we have waiting lists currently. So it's not like we've eliminated that, and this is just going to exacerbate that. But we also know, again, that you have to figure out how to live within your means, stretch it as far as you can, but there are going to be painful decisions that will have to be made if this is what we're looking at. And assuming, as the chairman said, that's what we're looking at, is 100 or so in SGF.
Thank you, sir. Thank you, Mr. Chairman.
Representative Bagley.
Thank you, Mr. Speaker. Mr. Chairman, I'm sorry. I elevated your position without votes.
Mean I get better pay?
Sir, I'm for that. The Secretary, Mr. Secretary, I appreciate you were speaking of being in DeSoto Parish with me this past Friday at the hospital there, rural hospital there, is going to build an addition and certainly trying to help. This list of reductions hit me fairly hard. I was an 8-year member of Health and Welfare before as a secretary. One of my helpers, Drew, back there, actually ran most of it for me, understands that. I think, and I'd ask the members, as they look at this sheet over on the other side, there's a $105 million cut, but there's a $218 million federal cut. We lose sight sometimes of the fact that we make cuts locally, the money that we miss federally. And I do understand if you don't have the money, you can't spend it. But again, there needs to be, originally when I was on health and welfare, and I sat up there about middle of this front row, and Katrina Jackson sat behind me, and every day they brought people in, old people, children, and they'd tell their story, and I'd tear up. And I'd have to turn around to Katrina, borrow a napkin from her, dry my eyes, and she'd give me that, and I'd turn around and continue. And I begged them, please take me off this committee. Now, some of these folks in here that are new, that are first year, they haven't ever seen that. But you see these yellow shirts out here? This place will fill up. Yellow, blue, red. They'll catch you out in the hall. They'll catch you out here on the side. You do not understand, because when we came in, it was $1 billion shortfall. We're only talking about $400 million or so now. And the things that you were cutting, and again, I'll ask this first question. The first one, eliminate pediatric daycare. And in this, you said that they'd like to eliminate to ensure the children are receiving services, and you're going to try to find alternative providers for them. So how are we going to, if we're going to cut $6 million, or actually $26 million total, where are we going to put these people where it's not going to cost any money? Anybody?
Yes, it's between a rock and a hard place.
A tough question already. Okay.
It's hard. We don't have a lot of great options, sir.
Yeah. Well, and again, you go down this list, and when these things came about, it was mentioned quickly that when we passed these things, we had more money. Well, we still have more money than we did when we passed these. Even with this reduction, we've got more money than we had when we passed. And there are many of us in here that were on this committee and on health and welfare when we passed all this in the first place. If you go down further, and it'd be hard for me to be in favor of any of this. But the big one for me is number 7, to eliminate the FY25 increase for reimbursement rate for ICFs and DDs. I fought hard to get the ICFs. That was for, at the time, they had a 2008 era Medicare reimbursement rate. 2008. Well, I'm sorry, they had a 2000. They were going to try to move it up to 2008. This is 24. Now we're going to talk about reducing it again. And I don't know if many of you know what ICF is, if you've ever been to one. The Holy Angels in Shreveport and actually they're not in my district, but I do help them as much as I can. They stand in the place of Pinecrest, who does the same thing, but Pinecrest is almost twice as much per day as Holy Angels. But if we pass this kind of legislation, we're going to run them out of business. When we got the increase, they were about to close anyway. I'd go there, and the lady would cry. The director of the Holy Angels would cry and say, please help us. Now, and I'm not talking about fake. She's watching this right now as we talk, and I know she's probably tearing up now. We're talking about real people. These people are here in these yellow shirts. They're real folks. They're going to lose money. And I think Representative Hughes was right on the spot. Representative, thank you. We're doing this right before Christmas. We're talking about this when they're expecting to have fun, and we're going to take some of their fun away from them. I don't, and again, we look at the state's only paying $5 million, and $10 million comes from the federal government. You can go on, we're going to, there was one of them about, the last one about eliminate Medicaid funding for inpatient graduate medical. As badly as we lack doctors in this state, and especially with the Medicare population, or Medicaid population, how can we be eliminating money for postgraduate education? I don't even understand the thought behind that. Help me. Why? I'm asking questions. I'm getting no answers. So I'm wondering, where we're going here with all this.
Sir, there are eliminations that pain us deeply, and I think the only way I could answer is kind of our limited scope of optional services.
Well, now, don't get me wrong. I don't think you or any of the ones that I'm watching are directly responsible for any of this. But these are things on paper, while they look good. If you'll turn around, there are people behind you that are going to be affected every day by what you say. I've got people that are blowing up my phone right now. They're like, please don't let them do this. And I do understand if you've got a $400 million budget crunch, somebody's got to take a hit. But again, these are people that depend on us for their life. And we made these increases, and all the newer representatives will know. You go back and look at our budget was much less when we made these increases. Even though we say we got more money, we've got more money now we made the increases. So where's the rest of it going? Why are we? And I know we're not picking on anybody. We didn't get a new LEH person to pick on, but he is certainly standing here looking at me right now. And I'm not on health and welfare anymore. But I am on appropriations. I can't in good faith vote for any of this or be in favor of any of it. I understand that you have a job and you were told to do something, and I certainly appreciate that as well. But as Representative Hughes said, I'm appalled by this list, the people that it touches. I know I used to take up for LDH all the time. Dr. Phillips was LDH, and people would say, well, you could just throw in all that money. It's a $16 billion. Well, yeah, but most of that money doesn't go to Dr. Phillips. She doesn't spend that, just like Mr. Harrington doesn't spend that either. There's only a small percentage of that. Most of that money's gone, even though it looks bad when we go to campaign to get reelected, and they're like, well, wait a minute, y'all throwing all this money away on LDH, why aren't you spending it? Well, we don't have a choice. Just like when we cut these things and we eliminate pediatric daycare, and it's $6 million, but $18 million we're losing, we can't touch. We can't do anything else. So I would say this is a tough job for you. I certainly don't envy what you do. I will tell the members, if we continue this path, these yellow shirts will fill this hall. I've seen it. The red shirts will fill the hall. There'll be all sorts of folks that come in. They will not be happy. And when you walk outside, in fact, Miss Katie Cochran back there now caught me in the hall one day and grabbed my arm and said, how could you? She's crying. She said, how can you do this? And I'd just gotten wiping my eyes and hear from her testimony. We talked about it. We're friends now. But at that time, she was not happy with me. All you members will have a chance to do this if we continue this quest to this. Now, I can tell you, I'm not going to vote for any of this. I'm going to fight as hard as I can to. But I do know we have to eliminate something. We can't keep everybody and do that. We have to stay within the bounds. And I don't envy your job to come in and do this, but I did want to have my say. And the folks back home and the people in this audience, we're not all for. I'm not for. The people that are involved, and I serve a poor area. I'm not in favor of cutting their services. I'm not in favor of cutting the few things that they've got. And we talk about old. My mom's 94 years old. That gets to me when you start talking about cutting old people's things. Why? They can't go get a job. They can't help. They've got to have help. And so we're going to do less for them? Does not make sense to me. So again, nice to have met you the other day, and I've had my say. Mr. Chairman, I appreciate it. Thank you.
Mr. Chair, if I can respond, please. Representative Bagley, the difficulty we sit in, and again, having been in the secretary role and was undersecretary since January, every one of these absolutely makes sense in terms of a rationale. As far as what they do, the people it cares for. There's no question about that. What we have to grapple with, especially in terms of what we were given, is, I'll say we take and we do away with one of these programs that's $5 million, $10 million. Then we got to go find
like number 7.
Like number 7. That means we got to go find it and take it away from somebody else. And that we're going to have the same argument.
Well, because
what Medicaid does is take care of children and seniors and people who typically don't have someone other than like yourself who's going to be an advocate for them. So that's going to be the difficulty is if you're saying, no, you can't do this, there's someone else in terms of this is going to pay that price, especially when you look at the costs that are built in to the mandatory things that we're already having to do. And so that's going to be the difficulty. I would love to be able to say, let's not do any of these or half of them. But then that means we got to go find that money somewhere else. And that means if you look at those programs, it impacts children and it impacts adults and certainly that Medicaid population. So I understand what you're saying. What we're looking for is trying to prioritize the programs that we identified, taking the money that we have that would be provided and do as much as we can within those priorities. And I believe that is the only thing we can realistically do and certainly bring back to the committee.
Well, and if you don't mind, let me answer that. Number 7, 2008 rates that we did, and we fought hard to get that done. I know Representative Bacala, who stepped out, but he was involved in this as well. Those places were about to close, and that cost almost twice as much to send them to Pinecrest or Pinehurst, which we're not going to close.
Right.
And so what we're going to do is if we close the ICFs, or if they begin to close, that puts more money in the other public places. It's going to cost us more money. We're going to end up spending more money by cutting money. That makes no sense to me either. So that's and the nursing home cuts. Again, we're cutting the most vulnerable of all the people in the state. I'm not sure, and I know you had a tough job. Please don't think that I'm picking on you because I think you are picking this stuff out. I don't think that. I think you're trying to do the best you can. I appreciate that. And I hate that you're the one that has to stand up here and do that. I wish I had met you last Friday and I liked you. So, but I could not.
Last Friday, Representative Bagley was a whole lot more fun. You're absolutely right.
I cannot sit here and allow this to come up before our group and let this go without some sort of response. I do appreciate
I fully understand your response, and again, there's going to be pain involved if we have to do this. And again, we're hoping it's only the 100, because as you know, there's 2 places that typically, when there's shortfall, you go to within the state. It's either going to be LDH or education.
No, I understand.
And it's one of the interesting things that I'm certainly have learned since being here in terms of January. So if you're talking about $400 million and we have to then go to that $200 million or $150, which we've done some initial type of analysis of, there's even a whole lot more pain.
Well, and I hope as a member of Appropriations, that I can help you with that. I plan to. This what I was presented with today. I plan to fight some of this because I just don't think it's fair. I know there are other members here, especially members that have been here for 2 terms, it's in their 3rd, and we've seen what it's like to have $1 billion hole and then a $2 billion right behind it, where they're talking about closing down nursing homes and they're going to do away with LSU football. We all understand that. And again, if the newer members, they have no idea what it's like to have a room full of mad, angry parents here and telling their stories about how their child is probably going to die within a year if they don't get help, and they can't get any help. And I've heard those deals, and some of the others of you have too. It's not anything that anybody wants to hear, but that's where we're headed if we can't curtail some of this, I think. Anyway, Mr. Chairman, I've said enough. Thank you very much.
Thank you, Representative Bagley.
Representative Amade.
Thank you, Mr. Chair. Good morning, gentlemen.
Good morning.
I have questions that I've tried to break into 3 different categories here, so let me see where I want to begin. Okay. Some general ones first. Does every state participate in FMAP?
Yes.
Yes.
Okay. Are their rates about the same as ours?
It varies dramatically based off of that income. If you go back to the formula, it's going to change significantly.
But their
And
formula also requires them to be between the 50% and the 60.
Correct.
The other percent.
Yes.
Okay.
But typically their match is going to be, many states are less than Louisiana in terms of the federal match.
Right. Give me a little refresher. Give me 60 seconds on rebase. How does it work and who decides?
In terms of rebates related to pharmacy,
As mentioned earlier,
nursing
the
home.
rebase rate that's going to get renewed in, was it 27? I think Mr. Ranto mentioned.
Yeah.
Yes, so there's 2 components to that. So based on the state plan, I believe they can rebase every other year. And then in that interim year, what I would call the interim year, you can do an inflationary adjustment. And so basically it's, that workforce piece I mentioned, the labor costs, food, there's some other, costs associated with that. But that's typically how that works. So it's every other year, and that is an ask. So, we come before y'all to ask for that every fiscal year. Inflationary, rebase, and repeat.
Okay, and so we, LDH or nursing
Yes.
homes?
Well, obviously, I can't speak for them, but it is a part of our budget ask, typically.
Gotcha. Okay. Let me see. Is there any difference between CSOC and wraparound services, or are they the same thing?
CSOC is a program that offers wraparound services.
Okay. How many TOs are involved?
For CSOC, I believe right now, Assistant Secretary Karen Stubbs could speak to this, but I think it's 4 full-time employees that administer that particular program.
Oh, so obviously it's done by contract. Because 4 people are not covering the entire state.
Correct.
Okay, and how many contracts do we have?
We have 1 primary provider, Magellan.
Okay, and they operate statewide.
Yes, ma'am.
Yes.
Okay. Let me see. Okay. So federal funds are our tax dollars coming back to us with strings attached, of course. And this question is visionary, so this question might not help us in the current year budget that we're about to face. How do we as a state begin to decrease our dependency on the federal funding? And here's why. The higher the level of government, the less efficient, the slower, and the more costly it is. So what services that we currently provide here in Louisiana using the federal funds, following the federal regulations, could we do a better job of if we decided to do those on our own, meaning the state take over?
Currently, those funds, in terms of that 71%, really impact almost all of LDH. For instance, if we're going to go and upgrade a technology system, IT, which we're looking at to be able to run our Medicaid claim system, we're typically there at a 50-50 match. If we weren't, then we'd have to come and ask for a whole lot more SGF in order to be able to do that. So it varies depending on what it is that we're looking at doing. But right now, we would be seeing a whole lot more reduction in services if we weren't able to see that kind of match in terms of services, because it supports both the actual clinical services as well as administrative services and functions, like I mentioned, like information technology, which is not an inexpensive part of running a large system like an LDH.
Okay, and this is the kind of answer I kind of expected to hear right now, but let me tell you why I'm asking, and then hopefully it'll give you something to think about, and we can talk about it again later, like next year. You're familiar with the Morganza to the Gulf levee system, right? You've heard of it? Okay. Years ago, we were trying to get that started, and we couldn't get any federal funds because they said we had to do a study first, or actually it's the Corps of Engineers that had to do a study. Well, the Corps of Engineers took 22 years to study. When they finally gave us the study in Terrebonne and Lafourche, we were excited, so we went on to Washington and said, hey, the study's done. Can we get some help now? Can we get some funding? And they said, no, that study's too old. You're going to have to start again. We need something current. Well, we figured out that the federal government was not going to come to the rescue, so we pulled ourselves up by the bootstraps, and Terrebonne and Lafourche parishes voted a tax upon ourselves so that we could get some levees built. And we've done that. And I believe it was last year that the first federal penny came to the Morganza to the Gulf system. And what we found out through the process was if we had initially started with federal funding, we would have spent billions more dollars, taxpayer dollars, to accomplish what we've already accomplished now for much, much less, and we still wouldn't have the levee system that we have. And so when we went from numbers like 11,000 households flooding in one hurricane down to 11, that was significant. And so I'm telling you this story to say that I think this is something worth researching. I know that the federal match money is very tempting because we're currently very dependent on it, but I believe that we can do better and that we could do it faster, more efficiently, and less costly, and without having to wait on the federal government and jump every time they say jump, if we just do some things in-house. So let me move to another question.
Respond.
Sure.
One of the things that I don't think that we from an LDH has been taking an aggressive approach on that we are now are looking at being able to operate differently. Yes, we're getting some of those funds, but to do what you're talking about, we need to be able to operate in a different way. So to an example, on the waivers, we have an opportunity to be aggressive on those. So we went to, and this sounds like a small thing, but actually we think from an operational standpoint, like you're talking about, it will make a huge difference. We went to CMS and said, we want an opportunity for all of our Medicaid participants to have to opt out of basically case management versus having to opt in. Now, historically, it's all been about opting in. It's a very different process, both for LDH and, frankly, the MCOs. Now, of course, they've had more questions. They've had pushback because their position has been all along that, no, they should be able to opt in. You can't, quote, force services. We have been able to prevail in terms of being able to change that basically through a waiver. We're also looking at some other waivers that Dr. P has been working on in terms of how we're addressing when people are transitioning out of corrections. So we're going to, over this next year, take a very aggressive stance in terms of going after these waivers to do our operations differently and not just frankly, them dictate how we want to do some of this operations. Even though we're getting those monies, it's our tax dollars that are coming back to us. And so that is one of the things we're doing now, which I think will lead us to where you want us to go. And we certainly would love to see less dependency.
Good. I like that attitude. Thank you. I think we can work together there. So we're hearing that 91% of the total LDH budget is spent on Medicaid. So what percent of Medicaid spending goes to treating conditions that are actually preventable? And the reason I'm asking this is because of the bubbling up grassroots conversation over the past several years is about health. And I'm sure you've heard the term. Right now, our system in America is really sick care, not health care. So yes. Knowing that the vast majority of conditions that are being treated are actually preventable, knowing that Louisiana seems to sit in 49th or 50th place in the nation concerning our health, tell me about that. What portion of the spending is going to preventable conditions?
Dr. Pete, you want-
We can get you that percentage. I think a great example that comes to mind is hepatitis C treatment, where we have an infectious disease. If we can treat it early, we can avert cirrhosis and a liver transplantation later in life. And often that transplantation would be done when someone's on Medicare. So it's complicated because we really have to find a way to capture these savings, but it doesn't stop us from doing that because we know ultimately those are still taxpayer funds that are going for that treatment. So.
Right.
And the other piece, Representative, I would add, in addition to that, is are we treating people in the right setting? We're looking at a pilot program right now, and basically regions 4 and 5. We've identified 6,000 to 8,000 of those Medicaid residents that we believe can be treated in homes versus in the ED and some of the other hospital type stuff. And I think from a population standpoint and cost, if we're going to truly get at bending the curve, it really has to be what you're saying. How can we truly be preventative and at the same time having people in the appropriate clinical setting rather than waiting for them to have to do a much higher acuity, which means more cost.
Right.
So that program, we know that we'll be able to implement this year and get some really, I think, good study out of that, working with a great partner in terms of Acadian Ambulance, actually. It's an interesting pilot program that they've actually that they have implemented in Texas.
Okay. I'm glad to hear this. But as you're talking about moving people from a clinical setting into another setting, this is good. But I'm talking about working to keep people from having to seek treatment to begin with. I'm talking about preventive medicine or preventive health opportunities. And this question comes because of an experience that I had, I think it was right here in this room just a couple of years ago, when we had a joint meeting between House Education and House Health and Welfare, because we were in the midst of trying to return students back to schools after the pandemic shutdown. And the question for that meeting was, how do we safely begin to bring back the athletics, the competitive sports? And in the conversation, we had the state health officer sitting right here in that chair. And at the time, I asked him that it's common knowledge that if, for example, you have proper vitamin D levels in your body, you'll be more able to resist viruses and more able to overcome them if you should come down with one. And I asked him, has anybody looked into the vitamin D levels of the residents in our nursing homes? And let's just say his answer left a whole lot to be desired. I'll leave it at that. It's part of the public record. You can go back and find it. So this is why I'm asking about what are we doing to work at promoting health, healthy lifestyles, healthy choices for individuals as well as for groups of people altogether. What are we doing there?
And I mentioned the quarterly meetings that we're now having, those operational meetings with the MCOs. One of the key issues with them has been case management, because within our PMPM that we pay, there is an absolute percentage of case management, and case management clearly gets at your focus, and that is, what are you doing to help manage this ahead of time? And when we have looked at those numbers of people who are actually engaged in case management, it is incredibly small. And typically it's only those who are in some chronic disease, like diabetes or something already. Mm-hmm. It's not really case management in terms of looking at how to basically promote health. One of the key things we are working with them on that we think will get us down this road beyond the case management is looking at screenings. Because that is another area that they pay 100% for. But when we looked at the actual percentage of total screenings that were happening for our Medicaid population, it was incredibly low. incredibly low. And so we're working with the Rural Health Coalition as well as LHA in terms of some specific types of numbers we want to look at in terms of screenings. And I think about all those areas that you're referencing in terms of cardiovascular, cancer, all those type of screenings that we could be more proactive about. That right now, typically people aren't doing anything with until they're way too sick.
Yes, and this is good. But once again, I'd like to see a step even before that. Like, we're screening for cancer. How are you educating the people to avoid cancer to begin with, for the cancers that we know of, that we know causes?
At least in the population health, and I'll let Dr. Pete respond to this as well, because certainly his expertise, that is where case management is supposed to be having an effect with people, because it's more one-on-one. And what we've seen in terms of population health is typically that's where you get real traction. It's more of that case management one-on-one in terms of interaction versus just kind of broad education.
Yeah.
Dr. Pete.
And I think just one specific example that ties into a couple of your points, especially the relationship with the federal government, is our WIC program and our Bureau of Nutrition Services, which is primarily federal funded, but we've made some changes in terms of promoting and only covering healthy foods and actually adding education around how to use these different vegetables when you buy them from the grocery. The latest evidence on obesity, which we know is a perpetual challenge, is exercise can play a role, but primarily it's nutritional intake. So we're still going to be 48th and 49th with obesity if we're still eating some of our same delicious but often unhealthy foods. So I think in this case, where we've got a taxpayer-funded program primarily going to young moms, we've been able to both provide healthier food and education and support.
Well, Dr. Pete, I would love to have a lengthy conversation and visit with you outside of a meeting, because this is appropriations after all. So I have one last topic, but I may not cover it if one of my colleagues is going to. Advertising? Okay. I'll relinquish my light right now because I think it's going to be covered by someone else. Thank you, sir. Thank you, Mr. Chair.
Thank you, Representative Amadei. Representative Chairman Bacala for a question.
Thank you. And I want to preface my comments by speaking first to the guys in the yellow shirts and those who are not in yellow shirts but are concerned. I think you're safe. All right. I think this is the first meeting. Don't panic. As many of y'all know who've been here for years, this is a process. And I think you guys don't feel like you're at the cliff right now. This is a long way from anything happening. To Mr. Secretary, I was asked to sit as an interim member like a week ago, and I had a busy schedule, so I kind of finished my preparation for this meeting last night. Ms. Blackstone will tell you my normal MO is to provide you with the questions I will ask ahead of time so that we could get answers instead of let me get back to you, which is probably going to happen today. But I will say in 2016, this is very reminiscent of 2016, 17, and 18. And I'll never forget that Commissioner of Administration was about to cut higher education. We kind of complained, and he sat at that table and said, I don't hear your complaints. I want to hear alternative solutions. So my idea here is I'm going to concentrate on maybe some alternative solutions rather than criticism of your plan. We're in a unique position here by the timing of this meeting in that we have just closed out FY24 and just begun FY25. So we have much better data today than when the appropriations process occurred during the regular session. Here's some important notes I think everybody ought to take note of. State General Fund for LDH was $2.26 billion in 19, and 2.28, 2.21, 2.01, 2.44 last year, the year that just closed. It was $2.58 billion State General Fund to support LDH. Next year, the current year that we're coming into, you asked for and received a whopping $568.6 billion or $1 million in increase in the State General Fund for LDH. So that If we went to next year and say you have to cut $100 million, it would mean your net over 2 years is a $400 million increase in SGF and not really a cut, just a reduction in your increase. I think it's important that we go back. Now, in last year's budget, the one that just closed, 2 years ago, we argued really hard that you guys were asking for $1.75 million more than you needed in SGF. There was a big argument about that. It had to do with the disenrollment. We asked for that cut in the Senate. We didn't do it. In the Senate, they ended up cutting $100 million. And guess what? You still reverted in the just past fiscal year. You're reverting a $75 million to SGF. You didn't use it. You didn't need it. So I will say right now, this $568 million that you asked for was based on miscalculation of at least $75 million initially that you did not need, because we based this year's budget on last year and last year and last year. So already your total starting place is $75 million more than it should have been. So let's just say 568 was 500 because you based it on a bad number. That's something we need to look at. Is right there. It might be $75 million that you really don't need. You thought you did. I don't even think they thought they did. They just grabbed everything they could. Then we can look at enrollment numbers. LDH never agreed with this committee in what the analysis said. But the truth of the matter is, in 2020, enrollment in Medicaid was 1.742 million people. It grew to well over 2 million people, but now we're back to those 2020 numbers. I think currently we're at 1.749 million. So we're back to a normal state of Medicaid enrollment. But yet, even though we have dropped since July of last year, we have dropped 300,000 people off the rolls. You continue to say we need more money to cover 300,000 less people. I think there needs to be a close reanalysis of that. Now, let me, the guys who are in here and been here a while know that medical vendor payments, which is what we seem to be talking about, you don't see a real breakdown in medical vendor payments as far as where the money goes within the budget. It's just a big budget, and then you pay it out as you see fit. The year that just closed, drug rebates cost us because it's a negative, less of a negative, $246 million. $246 million we lost in drug rebates last year. Direct pay to hospitals and LPR, we increased by $296 million last year. Nursing homes, we spoke a little bit about nursing homes and what they cost us. I have no idea why this happened, but we went from paying $1.148 billion to nursing home. Let's just call it 1.15. We jumped that to 1.4. We increased nursing home payments in the last fiscal year by $248 million. When a rebase cost us 30. You guys need to ask questions of your staff. This isn't your fault, okay? This is, you inherited this. Why did we increase over $250 million in nursing home payments? The MSEP program, which is the Quality Incentive Program, I know something about that because I ran a HCR or an HR on it that kind of created that thing. And it was locked in at $400 million, and it stayed $400 million for years and years and years. And it had a specific purpose. It went from $365 million to $732 million. You grew it by $366 million. A program, $366 million over the $400 that it was supposed to be. And quite frankly, I don't know how you could legally spend it in that category because it was very narrowly defined. And quite frankly, there should have been an evaluation of this program years and years to see if it's creating the outcomes that we desire. My guess is, as the federal government has cracked down on supplemental payments to hospitals, it was a vehicle used to make them whole, since they couldn't no longer receive the same level of dish payments and such. So dish goes down, well, don't worry about it, we'll just give you extra quality incentives, even though it has nothing to do with the quality incentive program. We're just going to shift money to you. That's my guess. But I don't know that. I hope you guys will dig in and find out. Clawbacks. Clawbacks, where we have to send more money to the federal government to pay because we overcharge, for the drugs. $60 million increase in payments. $60 million there. In total, the cost increase in a single year to that 306 medical vendor payments up by $1 billion. Now, it doesn't matter if it's federal money or state money. So you guys, I think before we talk about yellow shirts not getting all this funds, maybe we ought to ask, why did nursing homes get an extra $250 million in funds? Why did their payments go up by 20%? Legitimate questions.
Absolutely.
And you spoke to the fact, you're in the Coast Guard and trying to land a ship without thrusters might be a little difficult. I think y'all need to put some thrusters on this thing. Go back to the table, look at the year that just closed out, and say, hold on a minute. Y'all ought to be looking at these numbers and scratching your head and asking the same questions when solutions are there. LDH in 2015 had a plan on the table to put nursing homes under managed long-term care, which would have been kind of the capitated payments. Politics got in the way, and it never happened. All right? The whole supplemental payments program that you guys, use to supposedly make certain vendors whole came under a great deal of scrutiny, and basically CMS said, y'all can't do that anymore. But I think we're still trying to skate the rules, so we're directing too much money to certain groups. I could go through a lot of things, but you talk about, okay, let's cut the PACE program and save $6.5 million state general fund. Come on, guys, you know what's going to happen. You cut PACE program, you're going to shift them to nursing homes, and it's going to cost you twice as much. So that's not a cost savings. That's the PACE program is a efficient way to avoid nursing homes. It'll cost you more to cut it than it will to leave it in. Listen, I just kind of wanted to change the direction of the conversation to begin with. I've got about 20 more sheets of stuff we could go through, but I'm going to kind of let the rest of the members chew on alternatives and speak to the fact that we have an obligation not to just speak to not liking your ideas, but maybe presenting some of our own, of other ways to address this financial crisis that is less painful to the little guy who maybe has a special needs child, but who doesn't have the political clout of some of the bigger organizations. And I apologize for not discussing this with you ahead of time, but I was short-noticed on coming back to this committee temporarily and short-noticed on being able to do a lot of research on it. But this, I think we need to, look, I think we probably spent $100 million last year on advertising. Maybe it's $80 million. We don't need to do that again. We're through. We're finished. But y'all didn't reduce your budget by that amount in medical vendor administration. I think where that's good. We're just talking about medical vendor payment or vendor, but not administration. We can go into administration. But I've dug into y'all's budget years ago, like the big budget. Y'all need to just go through that thing with a fine-tooth comb. I mean, y'all were funding a hair salon for a nursing home. You were funding repeated tens and thousands of dollars just for somebody to come give pep talks to staff. There are a lot of stuff out there that is not critical to your mission that nobody would miss, quite frankly, and y'all ought to look at all them little things before you look at cutting a waiver, in my opinion. I come to you and say, I am willing, and I'm sure others here are willing, to do a deep dive into your budget and maybe look at things that are alternatives to cutting vulnerable individuals and vulnerable programs. And it just hurts my heart that we're here. But and listen, I will say it again. You guys started out on you inherited some of this, and you're still working to get the thrusters operational to turn the ship around. I will be willing to help you in any way that I can do that. So I will let you respond to my comments. And again, I have a lot of other stuff, but I don't want to hog the mic.
Well, Representative Bagla, you and I have not met before, but I assure you that I will more than welcome any detailed questions. If you ask any of the staff or representatives I have interacted with, it is detail that I'm going to go after. And so, yes, you have lots of questions. I want to be able to look at those details as well. I believe most of them have a context in terms of how that decision is made, the implications of one way or another, certainly like nursing homes, asking those kind of questions. So if you have them listed out, or if you want to meet to go through that detail, I am more than happy for us to be able to work through detail.
And again, I'll say that
we're not sitting here today in any way thinking that this is a great solution in terms of what we've talked about. And so if we can find and look at how we can restructure, redo things so we're not impacting people's lives, because as I said, we're going to these programs, we're looking at them and visiting them and knowing the difference that they're making, then that's what we'll do. So please, I'll make sure that Bethany, our chief of staff, gets that information, and we will certainly spend some time going through the detail.
I think we probably need to meet on the side somewhere in the next week or two, and so I can share with you the detailed documentation rather than trying to debate numbers, which are you got to sit across the table to do some of this. But I assure you that normally what I would do is send this to you ahead of time. But I'm first of all, I was short noticed on being put back on the committee temporarily. And I didn't finish my stuff till last night looking into this. So thank you. Thank you, Mr. Chairman.
Thank you. Representative Lyons.
Thank you, Mr. Chairman. Secretary Harrington, and I'm going to stick with some of the analogies because a lot of my questions were answered or even addressed. But I'm going to stick with Representative Bacala's analogy. He talked about thrusters. But in this particular case here, I think on the bridge of the ship, you have more officers, and I think a lot of us are on the bridge of the ship watching the course that you're directing right now. I believe individually and personally that these potential budget reductions that you guys listed here are easy. This is easy to look at as far as the choices of them. There are much harder choices that can be made that I believe we need to look at, and that's kind of the challenge that I'm going to ask you. You have done what you were asked to do. I think this might have been low-hanging fruit. In my tenure here, and going back to 2016 when we had the deepest deficit that we had, and this was summarized to you by my colleagues in the last hour, of how hard it was to work through some of these things and look at the people that were affected by it. You basically, in these potential cuts here, you gut the majority of these programs. And I haven't heard, and I would love to hear what would be the comeback, what would be the plan after these potential cuts, if they were to come to reality or even made. What will happen to the lives of all of these people that we actually serve in these regards? But that would be the secondary part of this, and that would be administered after the fact, per se. But, you can't tell me this is my potential reductions, and I don't have a plan of how not only this department is going to manage, but how we're going to manage the state in regards to services that we all characterize and that we provide. So it's just a tragic point that we come to when we have people have to come here and we talk about how we've turned their lives inside out again that rely on these services. And believe me, I'm not directing it toward you individually. It's just that the process that we have to go through. And Representative Bacala does a lot of diving. He should be a diver, but he does a lot in some of these things. And a lot of what he was talking about was where I was going, is the other places we can find monies to make these reductions at. Not only just in your department, but other departments that we have throughout the state to do that piece. But we've come accustomed to higher ed and then healthcare is where all those cuts immediately come at. And you guys are thrust upon the forefront of being the one of the bearer of bad news always. But I'm in agreement that there's other ways that we can find and make these monies cuts. $105 million can be cut from other places. Basically, we don't have to, get to these services immediately now and put our public notice, people on notice that, hey, you're in danger of cuts to changing your whole lives because we have a budget deficit. When there's so much beef, there's so much bulk on the other side of the fence that need to be looked at from that regards. So my challenge to you is come up with some other plan besides this one that we can look at. And ultimately what Representative Bacala said, maybe we all need to look at it, how we look at it together and come up with some other ideas that we have, because we've been down this road before. And it's been a highway, not just a road. And, I do commend you for coming and presenting. And I had never met you. I saw you here, and I was talking the other day when you came up. You remind me of the guy from the neighborhood. What's his name again? Mr. Rogers. Yeah, you came in. You have that peaceful look about yourself that everything is going to be great, and ultimately it will be. But in this era here, I want you to be that guy. Be that guy that we talking about the whole neighborhood, how we going to fix things for the neighborhood and come up with some other plans that we can look at. Ultimately, this one that you have here is devastating. And I don't see this as something that we even should digest in that regard. But thank you for coming here and answering the questions. The ones that I had, you answered them with my colleagues, so I don't have any more time to spend questions. Just I want to make that statement that I'm challenging you to come up with something else. And I hope we can. Thank you, Mr. Chairman.
Thank you, Representative Lyons. Representative DeWitt.
Thank you, Mr. Chair. I'll be short. I know it's hard to believe, but I will be. I just had a couple questions. And first, I want to thank y'all for serving, because as a former state employee, I know how tough it is and to be on that side of the table versus this side of the table, by the way. Just wanted to try to dive into vacancies and then on the possible fraudulent and or different, I would say, overpayments made, and what do y'all do about that? And maybe y'all can come back and bring to this committee what percentage of the budget is maybe overpayments or some fraudulent things that's going on in the different sections. And we have a lot of agency names. I'm new on the committee. I'm newly elected. So some of these different, I'm going to call them acronyms in the departments, I'm not real sure about. But if you could come back to the committee and really have some hard numbers that you could really do some cuts, because I'm not sure which one of these are actually facilities that the vacancies are in, and how many are actually in Baton Rouge or in the field offices and those sort of things. So if you could come back with us, and you probably have a certain percentage every year that are vacant every year. I think Mr. Undersecretary had mentioned maybe 8%.
That's correct.
Okay.
Yeah, currently.
So currently, and is that pretty typical?
Yeah, I would think so, but I would have to pardon ignorance on that, because I've been here for just about 8 months.
Yeah, and that's why I'm saying I'm not going to question you. Just next
fine.
time you come back, if we could have those numbers, if you could cut how many could you stand and still continue services?
Yeah, and I think if I could respond, Representative DeWitt, I think Representative Hughes had asked a similar question. I mean, 368 of the 545 vacancies are in the facilities, so I can't answer that now.
Okay.
He had asked more specifically about what does that look like dollar-wise, and so we will get that together and get it to the committee.
And I guess if you could make those cuts and be okay and survive, how many positions would that be, and what that number would be? And it may just be a couple $1 million. It may just be something simple. But again, we're looking at trying to tighten our belt, so to speak, and also with the Medicaid overpayments or any type of fraud that y'all have discovered or your predecessors have discovered in the past. What percentage of the budget is that, and what are we doing, or what are we looking to do to try to lessen that?
In terms of program integrity.
Yes, sir.
Yep.
That's all I have to say, Mr. Chairman, and I just want to give these gentlemen a chance to come back with those numbers, and I appreciate Representative Bacala coming to the table and giving his expertise, because I think these programs that y'all have to cut are really drastic, and I know y'all had a job to do to try to present us something, but I'm gonna kind of pony up on his back and try to find some inefficiencies or some reductions that we can make without cutting services. Yeah. Thank you, Mr. Chair.
Thank you. Representative Thompson for a question.
Thank you, Mr. Chairman. Good morning.
Good morning.
Appreciate the information. I could second what Representative Hughes has said early on, and Representative Horton. We can't do without this agency, but we can always be more efficient, I think. If it was it is our money, but you're managing it. We want to make the best solution that we can for the people of our state. And that brings me, I ask this all the time about, what about the states that are similar to us? You mentioned that a while ago, but you didn't go into any detail. But what about Mississippi? They're probably very close to what we are doing. And what is their budget, and how does that look compared to us, and what are they doing better than us that we would like to look at? Now, you don't have to tell people that Mississippi has something that we might like, but I'd like to know that, and you can speak to that for a few minutes.
I can't give you specifics today, but we will get those. The conversations we have had is with South Carolina.
That would be
in terms of comparison, and we can provide some of those numbers. And we were talking to them about programs and things they're doing. We also are having conversation with Tennessee in terms of they've been running a Medicaid program for a long time. The other one, frankly, that we are actually have a September 12th meeting scheduled is actually with Florida. Now, yes, their population and certainly is different, but believe it or not, when you look at, and that's where I'm originally from, there's a lot of similarities in terms of the populations and the numbers that they carry and how they're running programs. And actually CMS has suggested that we even look at some of these as we've gone after, as I referenced earlier, looking at some of these waivers and how they're doing. So we can bring back some of that very specific information related to them in terms of the numbers.
I think we could cover more ground and save more money, but make sure that we take care of the people of our state. Which brings me to the second one. You mentioned about 24-hour care in 3 locations. Where are they?
So we have 5 24-hour facilities, Representative Thompson. Yes.
Give me those.
Yes. So 3 are in the Alexandria-Pineville metropolitan area, and then the other 2 are in East Feliciana Parish in Jackson.
You know where Shreveport is, don't you?
I do. Have been many times.
You know where Delhi is?
I do. I've eaten at Thompson's Drugstore. No P, though, in the name.
You may know more than I need you to know. But I have heard this over time that that we're short-striped in that northern area. Could you address that?
I mean, I will address that I know that Baton Rouge is not the only place in the state. I will also address that the governor's tasked us to have a wider angled lens in terms of, you know, where we have potential assets and what needs to come to bear there. You know, y'all have heard me talk about workforce quite a bit. You know, those are areas that, you know, have heavy Medicaid populations, even though, you know, most of our folks do reside in the lower part of the state. I can't comment specifically. I know, look, over the years, and you've been here, you know, a lot of facilities had closed or transitioned or changed. And so that kind of predates me. But in terms of, Pete would probably tell you that, you know, a lot of the programs that we talk about, we would love to keep everybody in their community. You know, what would that mean for their family, you know, to be able to participate in their care? It's not always feasible, but it is something top of mind for us.
Good answer. But I want to see production.
Okay.
And
well, help me get there.
The governor has mentioned this. He wants to be taking care of the needs of the whole state, not just the southern part of the state or the northern part, but all of the state. And that's what I've always tried to push for, equity and take care of those that need it. If I ask you, do we have shortages in what area of the state for elderly and people that need food, clothes, and whatever that is associated with the people that we're dealing with at HD?
If your commitment to the North sounds familiar to staff, I think it's only echoed by our Surgeon General, Dr. Abraham, who I think is a great testament to the governor's commitment to North Louisiana.
Absolutely. But we can't put him as a pack horse. You know, we got the agencies are going to have to step up to the plate. Wouldn't you agree?
I think a great example of that would be in the maternal mortality and maternal health space. North Louisiana has some of our worst outcomes, both Region 7, in that case it's urban and rural parishes, Caddo and DeSoto, different challenges, same unfortunate poor stats. So we believe that resources should go to where there's the greatest need and greatest disparities. And unfortunately,
if I ask you about nursing homes, do we have enough in the northern part of the state?
I think we would have to get back with you on that, frankly.
In terms of
distribution.
And medical care, all those need to be discussed. And not saying we're going to do this, but we're only going to do it as far as Alexandria. That's halfway the state.
Well, I think that we can say that in terms of our Friday trips that we're making, that we've been to places like Monroe, Shreveport several times, DeSoto recently. So we know, and when I was here in terms of Louisiana from 2012 to 16 working with Christus, I lived in Alexandria and worked across the state. So yes, I have good friends in that part of Louisiana, and they remind me often that there is another part of Louisiana north of Alexandria.
You may know we had such a shortage of medical doctors, but we worked together with the university in Monroe, ULM. We have a medical school. Did you know that? And putting out 300 or 400 a year starting this year. They've already graduated a group. So the point is, we can get something done if we have an agency that sees the need for it.
Yes, sir.
I'm glad all of you nodded to it. So look at that, what the other states are doing, and see how we can make some positive changes. Thank you.
Thanks.
Okay, Representative Baralt.
Thank you, Mr. Chairman. Good to see you, gentlemen. I had planned to start with congratulations on your new roles, but condolences maybe feels a little more appropriate at this point.
We get both a lot, Representative.
I bet. So a lot of stuff's already been covered. I won't rehash unnecessarily anything. I do have a couple of questions. And I guess first a little bit of frustration on behalf of some of the new people. A lot of us ran for the first time on a lot of different things, but one of them being comprehensive tax reform so that we wouldn't have to talk about cutting healthcare and education. I said many times on the trail that I had no intention of cutting healthcare and education, and here we sit. So I think there are some short-term and long-term. I'm really excited, and I know that I've told you both this, or all three of you this, that I want to have those long-term conversations and whatever I can do to be helpful in that process. Short-term, I really just have two questions. Number one, we haven't really talked a lot about the hospital-directed payment. My understanding is that's uncompensated care. Is that correct? So that is, a lot of that's going to be dealing with undocumented. I know he mentioned $196 million increase. Could you talk, if you don't mind, just about how much we're seeing of an increase of uncompensated care, people who are showing up in our hospitals that don't have any coverage at all?
In terms of percentage, with the programs that we've had, especially DPP in the last few years, that number has decreased because of being able to support the hospitals. The DPP program, again, last year is going to be around that 2.9 or so.
Pretend for 1 second that I know exactly what you're talking about, but everybody else in the room doesn't,
Okay.
so you'll explain it.
The DPP?
Right.
The direct payment.
Okay.
That's the state-directed payment plan. Again, that is typically funded through some of the SGF, but mostly in terms of IGT, and then in terms of match, in terms of federal dollars. And what that's doing is then taking the volume of that uncompensated care as well as Medicaid, and then helping the hospitals be able to help cover that in terms of their cost. And typically with that program, you're able to at least reach cost, if not more, in terms of that population. So in terms of being able to support the hospitals, I think that actually it is a program that has been able to do that pretty extensively over the last few years.
So I guess my question more is, what have you seen an increase in the number of patients arriving at the hospital who don't have any coverage other than this?
No, there's not been an increase in terms of them arriving and having no coverage.
Okay.
Now, the piece that we are tracking at this point to see the impact is, it was mentioned the number that basically has rolled off in terms of the unwind, and where those residents are falling in terms of either having some coverage or basically with no coverage. And that's the piece we're watching right now to see if that's going to increase that population.
Okay.
Of the uncompensated care.
Okay. My bigger concern and question is, I know that we've had some conversations nationally about people coming in from out of the country receiving care and how are we paying for it. So what you're saying is this does not include a big increase in that.
In Louisiana, we recently were actually looking at that. We are not seeing a big increase at this point in time.
Okay. Well, that's good news. On the staff eliminations, you mentioned facility ratios and that this could damage that. Is that not regulated by CMS, how much we're required to have?
It is. The Secretary alluded to it, Representative Baralt, but I think what I would say there is in situations where we have a lot of attrition or turnover, contract nursing is really helping us bolster the facilities because, like I alluded, we have a shortage of folks to do these jobs in the particular area. We're already in a healthcare workforce shortage, and it is coupled by the fact that some of these are a little more, less urban areas.
Which, of course, is much more expensive.
Yes.
Yes.
Right. And this will be my final thing. So, I want to have the MCO conversation later, but on the FMAP specifically, my understanding, so we've got 68%. That's just for the regular Medicaid population, correct? If we were to go to the expansion, that's 90%?
90-10, correct.
90-10.
On expansion.
Okay. So I guess that's really more of a statement for all of us in the room as we talk about overall policy. That's one additional reason that if we take someone who is currently on regular Medicaid, the federal government is paying 68%. If we can find a way through all of our other policies to encourage that person to maybe get a job or take a promotion or move into the expansion population, number one, it's going to be better for them, but also it's going to cost us a lot less money because we'll go to only paying 10% and then in theory go from there to complete independence where we're paying 0%. So there's a graduated incentive, not only from a workforce perspective and just a health perspective and all the other reasons we want to encourage people to move to independence, but just that piece right there, that bump, is going to save us a lot of money in the long term as we're making policy even outside of this room.
And to your point, Representative Brawl, it's one of the key things that we're looking at and have had a different program around in terms of going after that population that unwound, because what we found was that's about 70,000 people. During that pandemic, as you recall, they weren't having to enroll every year.
Right.
And so now trying to find them to do the enrollment typically isn't happening until they're actually, quote, have a need. And so we are aggressively going after, if they do qualify, we want them on. But if they don't, then we don't want them on. So we've put some systems in place to look at things like workforce in terms of salaries and those kind of things to be able to do that on a quarterly basis as well. So there's those who need to be on and going after those who really are not yet on, because most of that expansion, as you said, it's still 90-10.
You mentioned this, and that brings up another question. How do you verify income? How does that work for y'all? And everyone else probably knows the answer to that, but newbie would love to know.
Well, we actually we did some. You have to verify through income. We did change because I think I had mentioned to this committee before that the accuracy in which we were getting information from the feds was anywhere from that 14 to 16% error rate. And so we went to one of the big three, Experian, I think is how it's pronounced, where they are looking at income based off of when people are purchasing things, because people have a tendency to give far more accurate information if they're wanting to purchase something and when they're not. And we do think that that's getting us much more accurate information at this point in time.
And how long has that been going on?
We started that back in the late spring.
Okay, so recent. Okay.
Yes, we started that recently along with the salary checks because that had not been going on during the pandemic either.
Okay, very good. Thank you very much.
Both of those are recent.
Okay. Thank you, Mr. Chair.
Representative Fisher.
Thank you, Mr. Chairman. Also, let me say thank you for initiating these talks, because they are needed if indeed we do have a budget shortfall. But I do want to just thank LDH for the work they have done over the last several years, because I have seen much needed improvement, much needed rate increases for the people that we serve. So I appreciate that, and it'll be disheartening if we have to go back and delete or recall some of these services. And I stand with Rep. Hughes saying this. For me, this is a non-starter, because we can't, not provide these much-needed services. But I will say, if there are some other means to cut something like advertising that will cover this, great. By no means, because we don't need to cut client services. But the question that I really wanted to address or have answered, I think Rep. Bagley sort of mentioned it. If indeed these are the services that has to be cut, if there's, during the budget shortfall, do we really save any money? And I want our members to hear this, because if these services are cut, as they are presented, then the services that we provide to our families and individuals, they have to go somewhere, right? Mm-hmm. And if they go somewhere else, it's going to cost us more money as a state to still provide those services. So can you sort of just expound on that if these services have to be cut, they still have to be serviced somewhere, and typically what it'll be in the emergency room or long-term care, which would be almost double or triple what you currently provide. So can you sort of best highlight that or address that?
I would absolutely say that, Representative Fisher, when you're making these type of cuts in terms of services, there's consequences. And that consequence is going to be in some kind of fallout in terms of either ED or others. The difficulty is, I said earlier, now, I would love to, if there's a way, and I know that this team would commit to it, if we can make cuts without reducing services, we're all in. Yeah. I mean, we don't want to be sitting up here having to talk about impacting people's lives. So if we can, work through that and find those details, we're going to. But when you're looking at this kind of impact, and especially when I am sitting and every day I get someone calling me saying that they don't have enough money. I mean, services in terms of what's being provided. But you're absolutely correct. There's going to be fallout. But that's going to be true whether we have impact on nursing homes or we have impact on ICFs. I mean, all those services, whether it's through basically the PDL in terms of pharmacy as it relates to, Medicaid. I mean, those all have consequences. So if we could make them without having some type of fallout, we would do it, and we will do it.
Yes, sir. Agree. So my point to the members is that for the DD population or the other in-home kind of services, if these are cut on the front line, they still have to be seen or serviced somewhere, right? And so the members will know that if we cut it here, the states don't save the money. It's going to cost us more money by providing those same services just in different capacity.
Well, and certainly the other piece of this that, yes, is going to have impact on the state, but it's also going to have financial and certainly quality of life impact on those families.
More important, yeah. Okay. I just want to make sure I highlight that point. Yeah.
They're also going to feel this in terms of the financial side, those families.
For sure.
Either through, as mentioned earlier, not being able to work the same or having to pay more out of pocket themselves. I mean, there's all kind of implications for those families.
Okay. All right, thank you.
Representative Owens for a question.
Thank you, Mr. Chair. Just a couple of quick ones. Managed care organizations, my understanding we have 6 of those in the state?
Correct.
So, Representative Amine informed me that we have more MCOs than most states our size. As y'all process, go ahead, sir.
Correct.
Yeah. So as you process what you're doing and you consider efficiencies, that may be worth taking a look at to see if we could get by with fewer of those.
You are absolutely correct. As part of the RFP, we're going to look at a different design in terms of concentration around geography, and then looking at the business need of how many do we need in order to effectively make that happen. One of the reasons why we're having the conversation with Florida on September 12th is to be able to do just that, because they went through that process about a year or so ago.
Good.
Yeah.
Okay. And I would encourage y'all, based on what you just heard from Representative Bacala, please listen to people like him. Y'all are all new in this. Or have you been in this seat long, Drew?
2 months in this particular seat.
Okay. The people who sat in your chairs before kind of ignored Tony and Brett and Brett Guyman, people like that over time. They just chose not to. And so we're sitting here as a repercussion. So I trust going forward that you'll be listening and taking the advice of people who've been down this road going forward. And Dr. Krogan, last spring you and I spoke about the issue of a vacated school in my home parish, and I began to wonder, because for the benefit of those listening or watching, there's a large former state school in Vernon Parish in my home. It sits on several dozen acres. It's been vacant for probably 10 years, and LDH is trying to decide what they want to do with that property. Are there other properties around the state that y'all are considering divesting? And any progress on that?
I'd love to get back with some more info on that. I think we're always looking at our properties and seeing if there's any.
And I ask that as a function of this. I wouldn't bring this up just to entertain people, but if we have such things like that around the state, and if LDH is just holding on to things to hold on to them, why not give them to the parish and just get it off your books?
And I think one great example would be sort of how we're responding to the Cooper Jackson settlement and some prior plans that were to build another 118-bed psych hospital in a city where we're already having trouble hiring people, as you've seen from the vacancy rate. I think that was going to be the other end of the spectrum, an absolutely expensive and probably ineffective intervention that we're trying to find more private sector solutions and alternatives there.
And my reason for bringing it up is that it feels like paralysis by analysis. Because, I mean, the state shut that facility down, I think, in 2014. And it's literally been sitting there, and the state is having to pay liability on it, to cut the grass, to monitor the asbestos or whatever else goes on there. And it's like, stop. I mean, there are all sorts of efficiencies that, and I think there are all sorts of inefficiencies that just grow as a function of bureaucracy and government. And I am sure that this governor who has appointed you guys is all about gaining efficiencies and being bold and acting quickly and cut the paralysis by analysis out. And so last thing I would ask is I would ask you take a look at the bewildering things that LDH occasionally is in the middle of. And let me give you this example. This just makes me want to pull what hair out I have left. Last year, I asked a question to the Board of Regents. Wasn't anything at all about you guys. I asked a question to the Board of Regents if any of our universities were conducting research with any of the three-letter government agencies in social media monitoring. To ask, are they working with CIA or FBI or working on any of these nefarious things that have been in the news? Because some universities around the country have. Turns out we were not working with any of those guys, but LDH was working with ULL to do social media monitoring. That LDH became in possession of federal money that they gave to ULL to come up and to monitor what people were saying about vaccines. That is just bewildering to me. Please look at stuff like that. That's not your job. It's completely not your job. And even if you are funneling federal money, there's a state employee who's managing this and who's funneling that money and who's getting these reports and reading these reports. And I got the reports, and they're just, I don't know why LDH would be doing something like that or putting up advertisements for things like Mpox. I see that down on Bluebonnet. Now we're advertising, we're encouraging people to take a vaccine for some virus that's recently appeared, and it showed up on social media. And my whole point is, please stick to LDH things, because someone's having to manage that. Someone's getting that money, and that's someone's job to do that. And so I know there's a million of those to do, and I know y'all are new. But please be empowered to do things that make sense, that will create public trust as opposed to make us have discussions like these. And I appreciate all your service.
I'd like to respond to two things. One is that, yes, a lot of that are grant-type dollars in terms of this marketing, which we still have control over, and we're in the process of addressing in terms of those grants or anything else. I think the overall approach that you will hear from LDH and this leadership is that basically that basic tenet of medicine. First, do no harm, and when in doubt, choose freedom. And so that will be our overall approach in terms of how we communicate and certainly in terms of driving our policy. Secondly, I assure you, as a hospital CEO and certainly as current secretary, if we can, in any way, whether it's with Representative Bacala, whoever, find solutions that's going to have less impact on people on our staff, we will not in any way let pride stand in the way of doing that. As a leader, okay, I am committed to being able to do the least harm to people I can possibly do, because I do this and I choose to do it because I care about them. And so to me, that's where we're going to come from as a team. And I know that every one of us sitting here today feel the same way in terms of where they are as a team. So I appreciate the comment, but I assure you, you're going to see that different component when you see LDH.
Thank you. And look, we as legislators are concerned with our citizens and delivering the services our citizens need and deserve. and these are tough moments. But be emboldened to do tough things. And anyway, thank you very much. God bless you.
Thank you.
Representative Coates.
Thank you, Mr. Chairman. Thank you. So one of the most concerning things that I heard this morning from Representative Bacala was about the funding of the nursing homes. And I really just bring that up because I recently got an email from a constituent that lives in a nursing home, and he said, their basic needs are kind of covered, but that he's not living the best that he believes that he could. And he was talking about the cost of food in a nursing home. And so with the millions of dollars that the nursing homes are given, like, why are they still struggling living in a nursing home? But we can talk about that more offline. But one of the questions that I had, because I heard ARPA funds from the federal government come up earlier, and I think we all kind of feel the room of how we all feel about these services that are being proposed to be cut. And I don't think that anyone here is ready to cut those services. But my question is, in this list, the federal funding, which one of these would be going away? Or is any of these ARPA funds that will go away that's specifically on this list?
Yeah, Representative Coates, I think, so just two quick comments for me on this. So if we chose, just for everybody's iteration, if we chose to cut these and reduce the SGF, we could not get the federal match for the service that we're talking about. Second, I think there's two on here in particular regarding ARPA funds. Line 11, the support coordination services had been previously funded with ARPA dollars to increase rates, and the legislature acted to then appropriate money to fill that hole when the ARPA funds went away. Pete, I'm not sure if there's another. I thought there was another one for OCDD.
I think it may have been 4. Yeah, number 4, the PCS and personal care services. I think another short-term influx of funding that was then put into the base rate in SGF.
Okay. Well, I guess my kind of point is, if we choose not to reduce any of these specific on this, are we going to be losing in federal dollars? And so then there would be another gap that this, you know what I'm saying? Am I making any sense?
If we opt to not make any of these changes, we would still be able to get the matching funds. Those would be in place.
From the Fed?
From the feds, yes. That FMAP would still apply in terms of these programs if we opted to continue to fund these from an SGF standpoint. And to your point earlier, we'll spend a lot of time in the nursing home numbers. I've actually been doing that when I was undersecretary and certainly now. One of the things that you're finding conversations change with the MCOs, hospitals, as well as physicians and nursing homes is that we are now making sure that we're also having outcomes, quality, as part of that discussion. Because to me, that's where the real return on investment comes in terms of if we're going to spend money, then what is it that we're actually, in terms of the state, getting back? And that has not been a conversation that, frankly, none of those have historically, at least in the last 6 or 7 years, have been able to do. We are absolutely looking at quality.
Okay. Thank you. Thank you, Mr. Chairman.
Thank you.
Chairman Bacala.
Thank you. And I pressed the button. I had one other topic I wanted to cover, but I want to jump in on some of the questions by some of the other members. Representative DeWitt asked about, cheating the system. And I think there are a lot of places where the system can be cheated and a lot of places where you guys could close those gaps rather easily. A couple of easy examples are there's LDH does not verify marital status. So someone can say, I earn $20,000 and therefore I am eligible. But if they were married to someone making $100,000, then they wouldn't be eligible. But y'all do not check marital status. There's really there's no database out there to do it. But you can look at income tax returns where typically someone would list married, with a spouse. While we're talking about that, it's never been done before, but the state could seek what is called child support. Mm-hmm. So I'm going to use the example, if a mother makes $20,000 and her children are eligible for Medicaid because of her low salary, but the children have a father making $100,000, and you could identify that because they would probably claim those Medicaid children as dependents. So you could go after that father for repayment of the Medicaid premiums that the state has paid because the dad is a deadbeat. But y'all have chosen, your predecessors chose not to do that. We talk about uncompensated care as though it's restricted to people who don't have insurance. It's much broader than that. It could be people who just don't pay their copay or whatever. I think that's something we just need to make clear, that UCC is not necessarily the uninsured. And if we make it easy for them to collect the copay from the state, they're not making the effort to collect the copay from the person who is treated. And we shouldn't say, don't worry about going after the person who owes you the money. The state gonna pay it anyway. Anyway, that's another point. Representative Baralt talked about moving people off of Medicaid. The truth of the matter is, and studies have shown it, Medicaid and other social programs are one of the drivers of poverty. Because let's just call Medicaid a $7,000 a year benefit. And it's income based. So if I make too much, I lose the benefit. All right. So if the cutoff, the magic cutoff is $25,000, right? And my employer offers me an extra $200 a month, give me $2,400 a year. I can't take the raise, or I have to cut my hours because I'm going to lose a $6,000 benefit. It's a benefits cliff. So programs such as Medicaid, because there's no taper off in eligibility, it's the greatest impediment to prosperity I think this nation has ever known. And quite frankly, it's not just Medicaid. When you stack all the programs together, it's quite easy for somebody to have $15,000 worth of government benefits that they lose if they make $1 too much money. And we are locking people into poverty forever because they can't afford to replace $15,000 in government benefits because of a $2,000 a year raise. Quite frankly, I don't know how you fix it, but that is a reality that we live in, and we will never prosper as a state as long as we don't have a solution. Representative Baralt talked about eligibility, and you guys mentioned, you're now checking, you didn't say it, but it's loan information. But I think eligibility, you ought to also try to identify not just the what's called the custodial parent, but the other parents. What you'll find is, and I think we've already found this, we never could do it twice because the Department of Revenue under the previous administration wouldn't cooperate. They cooperated with us one time, and then they never would again after they realized the data was so damning. Go to those income tax returns. Look at them. And if someone, modified adjusted gross income is a household income, not everybody in the house, but if you're living with your dad, look, Medicaid is disadvantageous and to marriage. If you're married, suddenly you might not be eligible. Stay unmarried, so it prompts people to not stay married. Representative Owens mentioned the MCOs being 6, but there's really a 7th, and that's the I think it's who does it, the
PBM.
not the people.
Pharmacy?
No. I'm talking about you have about 70,000 who enrollees, or how many that are not under MCOs, the direct pay?
Oh, fee for service.
Fee for service. Fee for service, y'all contract with another company to handle fee for service, correct?
Yes.
So maybe it's time to start looking at putting more or everybody perhaps under the MCOs. It's capitated costs. They have and listen, I think the fee for service for years and years, they just kind of surrendered. We can't do it right because the state won't invest in the software, which has cost hundreds of millions of dollars in order to do their job properly. It's a subject of repeated audits where we're making payments that should not be made to vendors. And all they have to say is, as soon as the state will invest in a couple $100 million in us to update the software, then we'll be able to do it right. MCO's got the software already. And Representative Coates mentions nursing homes. The last time I checked, we were 50th. And Representative Coates, the measure of how they do that on the federal level is bed sores. And the more bed sores you have is a direct indication you're not being taken care of. So it's very measurable, and we're last. And it's a shame, but we're last. Maybe we got up to 49th, I don't know. But the last time I checked, we were last. And when you talk about nursing homes, it's really crazy the way we pay nursing homes. We pay for empty beds. If someone has a nursing home bed and suddenly they're critically ill and they go to the hospital for 2 months, or they go to hospice somewhere, we continue to pay for that bed even though we're not using it. And just so you know, most of the nursing home patients are what's called dual eligible. They have Medicare that covers the hospital stay. Medicaid covers the nursing home bed. There's no incentive to take care of those bed sores because they're going to get paid whether they there or in the hospital. So we are create a situation where there's not really an incentive. If I told the nursing home, as soon as that person leaves because they got bed sores all over their body, to go to the hospital to be treated, you're not getting another dime. Guess what they would do? They'd make sure they had less bed sores. But that's a policy change that needs to take place with you guys. Simply say, if they're not laying in the bed tonight, you're not getting paid tonight. And guess what? I bet quality of care goes way up. But you got to be willing to take the heat for doing it, because that's, anyway. The last thing I will mention.
And Representative Bacalak, you're absolutely right on, and spot on in terms of policy changes. And we're in the process of looking at what CMS is going to allow us to do and what we need to push back on them on. But I assure you, just that one change that you mentioned, I've spent my whole life in healthcare and understanding the reimbursement process, incentives, aligning those with quality. And I assure you that you're going to, as a legislative body, if we made one policy change like you're talking about, your phones are going to blow up. And that's where we all have to be aligned in terms of that quality matters, and it absolutely impacts cost. And we're going to bring those kind of policy pieces to the legislative group and make sure that you're aware how it impacts, why we're doing it, but we are going to do those. And clearly, we want people on the rolls in terms of Medicaid who need to be there, but they need an off-ramp. And you're absolutely right in terms of those policy issues. But those are things that we'll have to get to. But today we're trying to deal with an immediate issue. Those policy things, we know that this next year are going to have to be a key part of what we go after. Drew, I know you had one response.
Just if you'll permit me briefly, Representative Bacala, I wanted to comment on the benefits cliff, and something that I've personally talked to the governor about and Secretary Showen with the Workforce Commission. We're pursuing on the Workforce and Social Services Task Force that I currently sit on. This is absolutely in our dashboard. The governor has told us multiple times we have to move people from dependence to independence. We got to bring our folks home. We got to train them. We got to educate them, and we got to get them into the workforce. We have to rebuild this economy, and it starts now. We have to do that. It's not an easy task, but I will tell you, it is something that I have watched for years. I worked in the federal system for a long time, helping constituents, that were robbed of a benefit or maybe should have been on a benefit and couldn't get there. But it takes a team effort to line all this stuff up and actually tell the feds, this is where we think we can make some changes that are super impactful for our population, to get them off one particular program, get them that job with better insurance and better benefits.
And I would like, if you don't mind, Reverend Broccoli, one other comment, and that is respond to your question, because we, in terms of marital status, when we put in that change in terms of looking at the Equifax, basically, and Experian being able to give us that information, that was to get complete information, not just in terms of their purchase. We also, at the same time, 2 months ago when we did that, are looking and have a totally different way to be able to go after the marital status verification.
Thank you.
So we have made that policy change.
I told everybody I'm rusty. I hadn't been here for a year. And listen, what I'm talking about, when you talk about making changes to the policies relative to nursing homes, you do save money. I mean, we just saw you spent an extra $400 million, whatever it was, last year, and maybe if we made these policy changes, it would result in some savings. Now, look, I'm kind of hitting this quickly. I'm shotgunning this, but let me just bring one more thing into play, because we're in the unique position here of having the ability to look at the year that just closed out. I think it's kind of interesting that within your agency, spending jumps in June. So at the end of the fiscal year, it looks like there's a hurry up to spend a lot of money that maybe you don't need to spend. All right. And I'll give you a few examples. And look, this doesn't solve a budget crisis, but tens of millions grow to hundreds of millions if you look at it often enough. In medical vendor administration, the average monthly spend for other charges is $9 million. You jumped to $15 million in June. Average 9, jumped to 15. I know there could be some quarterlies, but I haven't seen a reflection of the previous quarter marks showing those increases. In health and hospitals, Office of the Secretary, other charges went down. In Office of Public Health, you jumped from 16 million average per month to 27 million for that month. Just other charges, smaller amounts, but disabilities, 1.7 to 2 point something. It looks like that increase in spending, I don't know. I just always kind of say if somebody's spending a whole bunch of money at the end of the year, maybe it's, okay, I got it. Let's spend it before I have to turn it back in as surplus. Please look at it and see if all those last month expenditures were necessary or just, I don't want to get the money back.
Right.
All right?
Yes.
Appreciate it.
Okay.
Final question, Representative Baralt.
Thank you, Mr. Chairman. I'll be brief because I know everyone's ready to go and get on to Labor Day. Back to benefits, Cliff. I feel passionately about that. I just find it immoral that we have people that feel like they can't better themselves because they're trapped with the benefits. The good news is that I do think that there have been previous programs that have been put in place, but I don't know why they're not as widely used. LAHIP. My husband's a physician. He has a medical practice. I didn't learn about this until I got here. I don't know why he didn't know about that, why the office didn't know about it. Had some other conversations with people. For the benefit of those who might not know, this is a program, as I understand it, please correct me if I'm wrong, that when a person is on insurance, is on private insurance, and then, I don't know if it's specifically for maternity, I know it works in that space, becomes pregnant but didn't have maternity care, that Medicaid will pay to keep them on their private insurance, pay that difference in their premium so that they don't drop their insurance and get on Medicaid. It's a win for the physicians, a win for the mom, a win for the state. It's a win all around. But they don't even know about it and or have tried it and had a really hard time utilizing it. So can you talk a little bit about that program specifically, how we can fix it? Because I think it's a brilliant idea. I don't know whoever before me came up with it, but it's brilliant.
I think we totally agree. It's one of those things we've come in and been like, trying to sort out why the utilization is so low, because at the front end, there's an immediate fiscal assessment, which is this going to cost the state more or less to pick up the cost of that premium? And we don't cover them unless we know it saves the state money, and we don't have a lot of programs that we can guarantee save the state money from the jump. So I think this is something we're taking really seriously, trying to figure out what are those roadblocks. If they're logistical, if they're bureaucratic, we'll cut through that for sure. One benefit cliff program that we've already rolled out, or should go out the next month or so, is the Medicaid purchase plan. So these are folks with developmental disabilities. If they need these services that Medicaid provides, it's honestly way better than a lot of private insurance in terms of personal care services and services in the home. And they know if they get that raise, they're going to lose this service. So they politely decline, even if they're doing a great job. And this was something we could do within our own rulemaking authority, and we jumped on it starting in February. Here we are in almost September, and it's still taking long to launch. But they're going to be able to pay, the individual is going to pay a premium to maintain their Medicaid insurance, and that'll go up from 110% of FPL to about 145%. Small is probably about 2,000 individuals, but for them, it could be pretty huge. So, thanks.
Thank you.
Okay, that was the last question. Once again, from my original comments in the beginning, the hay is not in the barn. It's still in the pasture, okay? We may have baled it, but it hadn't been picked up, put and stacked in the barn. I think it's important that everyone recognize that now you can see the complexity of addressing a budget shortfall. And within each agency, and look, this is only the first, and I appreciate Secretary Harrington, Undersecretary Moranto, Dr. Krogan. You were the first, and sometimes that's not the easiest to come in here and to this committee to be asked the difficult and tough questions. A lot of difficult decisions will be made this year. And that's why I once again emphasize that the legislature must take a holistic approach at how we address budget shortfalls this year and in future years. And that holistic approach has to take into consideration streamlining services, being better at our jobs, reforming our tax structure. All these are things that we must do at the same time. And since we're the first part of this process, I appreciate you coming today. We have three cards, colleagues. Drew Moranto, present, willing to provide information, Louisiana Department of Health. Dr. Pete Krogan with Louisiana Department of Health, present, willing to provide information. And Michael Harrington, Louisiana Department of Health, present, willing to provide information. Also, this morning, the committee received 11 statements from members of the public regarding today's agenda item. They were forwarded to each one of you this morning, and I do want those statements to be part of the committee record. Is there any other comments? Anything from the public? All right. Motion's been made to adjourn. This meeting's adjourned.